Dr. Rhoads, welcome. Thank you so much. So, what made you decide to start up Umoja Health and these pop-up vaccination clinics?
So, Umoja Health actually started as an effort to increase awareness and participation in COVID-19 testing for the African American community. What we could see across Alameda County, and particularly in Oakland, was that even though the rates of COVID-19 infections were high in certain areas where there were high proportions of African American people, the testing rates were not as high. And we didn't immediately attribute that to people not wanting to be tested. We thought that it might be related to access to testing and how testing was delivered. So that's how we started doing the pop-ups. The pop-ups themselves allowed us to reach people who were first-time testers who had never been engaged with the system or who were outside of the system in terms of having health care or having an accessible health care system that they were attached to. And because we were able to reach such a high proportion of African American people who had never been engaged before, Alameda County decided to give us an allocation of vaccine, knowing that we would be able to probably reach those same communities. Today, for Alameda County, it's number 18, but officially for a few of us who have been together since we started the work in San Francisco, this is officially number 20. Well, we know that we have tested nearly 3,000 people.
Wow.
Over the course of the past year. And then in terms of vaccination, we've reached now, I think we're closing in on 1,500 vaccinations that have been delivered. When the California Office of Statewide Health Planning and Development releases the hospitalization data for 2020, I'll be asking the same questions. What happened to people when they showed up in the emergency department? Did they get oxygen immediately? Did they get admitted to the ICU? Were they triaged emergently, or were they left to linger in the emergency department? Were they discharged repeatedly and kept coming back but couldn't get admitted? Right, so these are questions that give us a systems level approach to understanding disparities, which is a population level problem. Population level problems have system level drivers rather than thinking them as like individual level problems. So we're actually in the process of applying to the county's RFQ for folks who will do mobile vaccination. We're looking to buy a small van. And that will be, branded with our Umoja logo. And we have small refrigerators. So we have the equipment and we're ready to go. We just need the mobile van. We've been planning with some of our partners from Glad Tidings in Hayward that have a very well-identified group of folks who are homebound. And so we'll probably be starting with them. Yeah, so the systems that are being used for getting an appointment often sort of it's like the Hunger Games. Mm-hmm. So you have to have the capacity to sit at your computer and refresh the computer over and over, which means maybe you're not working. You have to have a computer, right, and you have to have internet access. And so the way it's been rolled out, instead of segmenting appointments for different communities and different populations, it's been put out there as sort of a free-for-all. And so it's, as I said, it's like the Hunger Games and survival of the fittest or survival of the best resourced.
Right.
And so part of what we've done is we said we're going to remove the barrier of the electronic registration. So even for the people who are on our list today, who we are expecting to see for vaccination, we don't expect them to register. And then we provide registration on site, which also gives an opportunity for community members to participate in that process, for people who come to our sites to actually see their neighbors participating in the activity, which I think helps people feel more open about getting vaccinated, asking questions, responding to surveys, sharing data, for example. And so we are effectively addressing directly the issue that the state and the counties have come up against, which is that the way it's been rolled out favors people with cars and computers. And that's not always the populations that are, quote, hardest to reach, or the populations who have had the highest rates of COVID during this pandemic. I'm always conscientious about language that suggests that the people are at fault for whatever the health condition is. And I feel like vaccine hesitancy is so racialized. And the reason it's racialized, in my opinion, is because we have large communities of white, people in the Bay Area who absolutely are against vaccination, but we never use the term hesitancy with them. And then the other side of that is if you use the word hesitancy and you get comfortable with it, then when we find out that access is different by race or that fewer Black people have gotten vaccinated, then we effectively have an opportunity to blame them for that rather than looking at ourselves and our delivery system and asking, can we do a better job providing access to and helping people feel comfortable with vaccination? And that includes answering questions. So the idea of hesitancy is kind of silly because this is a new disease that we're dealing with, and of course people have questions, and then when there's a new vaccine on the scene, people will want answers. So the idea of hesitancy, I think, is deterministic, and because it's racialized, it sort of traps us into, the old way of thinking that our delivery systems don't need to change, but that the people need to change. And I would argue that our delivery systems need to change if we're really going to get to equity. I think my biggest message, though, out of all of this is really to say that every one person who gets vaccinated, we get one step closer to community immunity, which is the pathway out of this pandemic.